very nice study from Sweden that they look at 20,000 patients born with congenital heart disease, and they follow them for 40 years, and they compare the risk of developing heart failure they assess the risk of developing heart failure compared to the general population. And not surprisingly, they found that if you are born with heart failure, you have 100-fold higher risk of developing, if you are born with congenital heart disease, you have a 100-fold risk of developing heart failure during your lifespan, and this is following them only until 40 years of age. But even more, if you are born with a complex congenital heart disease, 1 in 7 will develop heart failure. But I think one of the most important things of this study is, of course, obvious that in pink you have the patients with congenital heart disease, and in blue patients with non-congenital heart disease. Obviously that if you are born with a congenital heart disease, you have a higher risk of death. But in the right panel, you see what the difference is if you have congenital heart disease and you develop heart failure. You have a 65% risk of death during your lifespan. This is a recent paper published at the end of last year with data from the US of admissions of patients with congenital heart disease and admissions for heart failure. And they look at 26 admissions for heart failure in the country. 5,000 of them were, or almost 6,000 of them were congenital heart disease patients. And you can see that over the last 10 years, the number of admissions for heart failure and congenital heart disease has doubled. And this is only going to go higher. And what happened with our patients when they die? This is another US study that, when they are admitted with heart failure. This is another study from the US that they look at all patients that came to the ER with heart failure, and they divided them in congenital and non-congenital. And they see that if you have a congenital heart disease and you make it to the ER, you are more likely to be admitted, and also you are more likely to die. So, which is not a surprise. But we will look at what patients really, what is the main difference between the heart failure and congenital disease in heart patients and non-congenital patients is mainly the age of our patients. Our single ventricles will make it to the ER for heart failure in the younger, in their 20s or 30s. Our biventricular hearts, they make it in the later in life. But the average age of our patients with heart failure is younger than patients with heart failure with acquired heart disease, which is going to be a problem when we have to offer them options. And of course, it's not, this is one of my favorite studies, a very old study, but it's I think this 10 years later, still representing the difference between the two worlds. If you have an acquired heart disease heart failure patients, the base of your pyramid is the neurohormonal modulation. That's what we do to them, give treatment, give medication, and do things afterwards. If you look what we do in congenital heart disease, if we have somebody with heart failure, first we're going to look at what is wrong, is anything to fix, and just at the top, we have the neurohormonal modulation. And the reason is because even nowadays, and this is 10 years later of this study, we're still not having much evidence of what to do with medical therapy for this population. We really don't know, but there's some news that came out from this paper last year, which is for many years we had been complaining that we did not increase the number of transplants in congenital heart disease. These are data from the US. As you can see, in the last 8 years, we have doubled the number of transplants in congenital heart disease patients. And this is US data, but is true in Europe and it's also true in Canada. But the best news of this paper is actually we also have improved the survival. So on the left panel, you see is the first year survival. In blue is patients with single ventricle. In purple is patients with a systemic right ventricle. And patients with biventricular heart, congenital heart disease. And in yellow is patients with acquired heart disease. As you can see first, if you have a biventricular heart and congenital heart disease, your survival is exactly the same than a patient with acquired heart disease. So there is no reason not to transplant these patients. The Fontan, if you remember early graphs of Fontan transplant, the mortality was something like this. Mortality perioperative was around 25%, and after the patient survived. But you can see we got much better in the perioperative period. The first year is still an attrition rate. Patients die during the first year. mainly the hypoblast. But look at this. This is the best news that you can have for a transplant. If you make it to a first year, and you make it to 3 years, and you have a ventricular heart, your survival is much better than acquired heart disease patients. So at 10 years, our patients live longer than patients with acquired heart disease. Since we changed this model, actually we increased the numbers. We are transplanting more patients with this model because now you have all the people that are looking at the patients are congenital heart disease providers, so it's easier to get the numbers up. But also we are transplanting more complex patients, so systemic RVs and Fontans. But I think the most important part of this model is this. This is when we changed the model, and this is the mortality we had before the model, was a 21% mortality at discharge, and we have changed significantly, almost reduced by half, the mortality of the patients when they go home. So our survival is much better just having the expertise concentrated in a congenital heart disease team.